Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our webinar titled Quality Measures in Value-Based Payment. I'd like to mention a few logistical items. You'll be able to download a copy of today's presentation from the caqh.org website tomorrow. Also, a copy of the slides and the webinar recording will be emailed to you in the next day or so. We will have time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. This webinar is part of our series on the topic of value-based payments. Today we will start off with a CAQH core presentation on our work on VBP with a focus on quality measures. We will then move on to our featured presentation on quality measures in VBP from Aparna Higgins from Ananya Health Solutions. So let's get started with our first presenter, Lena Gebramariam, Manager at CAQH Core. Welcome, Lena.
Thank you, Jessica. So today, I just want to tell you all a little bit about the CAQH Core report entitled All Together Now. CAQH's expertise is in bringing healthcare stakeholders together to develop and agree upon and adopt business rules that improve the exchange of electronic transactions. The same expertise, experience, and resources can be used to support the development of a sound operational system for VBP. The CAQH Core conducted a study over 2 years that found that there's a need for this industry collaboration to minimize variations and identify opportunity areas that, if improved, would smooth value-based payment implementation. Creating or participating in a value-based model requires an intensive amount of time and resources for all stakeholders involved. The research identified the biggest barriers to success and found that the lack of consistent expectations created inefficient business transactions. The report details 5 potential opportunity areas for action, which, if addressed, would minimize industry variations and, if improved, would smooth VBP implementation. I encourage you all to take a look at this report, and if you only take one message away, let it be this. None of these potential opportunity areas for action will be successful without industry collaboration. No one organization is going to be able to solve all of these challenges. Without collaboration, VBP models will continue to be plagued with opaque payment structures, ambiguous targets, and decentralized data structures. Moving on to the next slide, you'll see the 5 opportunity areas outlined here. CAQH Core's vision is a common private or public infrastructure that drives adoption of value-based payment models by reducing administrative burden, improving information exchange, and enhancing transparency. You'll see that the 5 opportunity areas listed in the report are data quality and standardization, interoperability, patient risk stratification, provider attribution, and quality measurement. We will be expanding upon this research by launching a multi-stakeholder advisory group this fall, which will help CAQH Core staff by identifying and selecting specific strategies for a CAQH Core subgroup to pursue. And this will result in a predefined work product. More information will be shared with CAQH Core participants in the near future. But as you'll see, the 5th opportunity area laid in this report was quality measurement, and that's why we're all listening in today. In the report, we outlined the industry challenge that the quality measures are clinical. Gathering data and producing reports is an operational burden, and providers reported 3 overarching challenges across quality measure programs: too many measures, too much reporting, and too little insight. Research found that 850 unique measures collected in 33 CMS programs, and only a third of these measures were used in more than 2 CMS programs, which means that the average physician spends 15.1 hours per week entering information just for the sake of reporting. And on the next slide, you'll see some of our recommendations to improve this problem. CAQH Core recommends supporting industry efforts to address quality measure challenges and promoting standardization by providing education to address the need to improve consistency in quality measures, reduce the number of quality measures to decrease collection burden, and require quality measures to be actionable. The effective measurement and process performance and outcomes is foundational to VBP. And while there is a shifting focus from process measures to patient-reported outcomes, process measures are foundational for measuring value. However, effective patient-reported outcome measures can capture patient health status while keeping provider collection burden at a minimum and empowering patient decision-making. And so now that we have a little bit of that foundation, I'm going to pass the call on to our featured guest speaker, Aparna Higgins, who's the President and CEO of Ananya Health Solutions, as well as a consultant to CAQH Core. Aparna, thank you so much for joining us today.
All right. Thank you, Lena. Really happy to be here with all of you today. And what I'm going to do today is really provide an overview of quality measurement and its role in value-based payment. And our hope is that at the end of the webinar, you'll have a better understanding of how quality is measured in value-based payment models today, what are some of the challenges associated with measurement, and then also talk a little bit about what should measurement really look like as it relates to value-based payment in the future. So before we start talking about quality measures and its role in value-based payment, I just wanted to set the stage a little bit and share with you some data on why value-based payment to begin with. So recently, the Centers for Medicare and Medicaid Services, they released the National Health Expenditure data, and that data showed that by 2026, the U.S. is expected to spend about 20% of its GDP on healthcare. So there's a growing percentage of the GDP that's going towards healthcare, which means obviously less is available for other kinds of services such as education infrastructure. And not only that, as this slide shows, the U.S. compared to other developed countries spends a much higher amount on a per capita basis on healthcare than other developed countries in Europe, Australia, New Zealand, and so forth. Next slide, please. So then the question arises is, well, we're spending a lot more. Are we getting a lot more for what we spend? And again, this comparison chart that's based on data released by OECD actually shows that we're, in many ways worse off than a lot of these countries that spend a lot less than the U.S. in terms of some key health indicators, life expectancy at birth, infant mortality, obesity rate, as well as daily, smokers in terms of percent of population. So as you can see, we're spending a lot of money, but we're not getting the kind of outcomes that we would expect for the money that we're spending. Next slide. And so hence there's been a shift in terms of changing the way we pay for care in the U.S. from a purely fee-for-service basis to what is called as value-based payment. And most of the focus on value-based payment has been on contracts between payers, could be plans, Medicare, CMS, state Medicaid agencies, and providers, which include clinicians, clinician groups, hospitals, and so forth. And so there have been a variety of models that have been tested. And what I wanted to share with you on this slide is a framework that was put together by the Healthcare Payment Learning and Action Network, which is a multi-stakeholder collaborative that involves the Centers for Medicare and Medicaid Services, but a number of large national payers, providers, health systems, and so forth, are really working to advance the adoption of alternative payment models or value-based payment. And what the LAN, as they're commonly known as, what they came up with is a framework to help organize the different kind of models that are being tested. So on the left-hand side, you see Category 1 payment models, which is essentially fee-for-service, which is no link to quality or value. And then Category 2, which has fee-for-service with some link to quality or value. The question is, how is quality measured? And I'll talk about that in a second. And then moving from there on to Categories 3 and 4, where plans or payers are entering into shared savings type models with providers, all the way to the right-hand side, which is Category 4, which are truly population-based models where providers are going on full risk or taking on a global budget for managing the health of a population. So what we're seeing right now is a lot of experimentation in Categories 3 and 4 in terms of the kinds of models that are being experimented with, the amount of shared savings that a plan and provider might enter into. So a lot of variations on a theme, so to speak, but fundamental to all of these models is the measurement of quality, because people want to know, okay, how are we doing relative to outcomes for a particular population? And I think people are especially attuned to this, especially those who've lived through the managed care experience of the 90s, where I think there was a concerted effort to control costs, but then there was also a lot of backlash because, you know, there wasn't adequate measurement of quality, or people felt like there wasn't an adequate measurement of quality, and therefore there was a lot of discussion about skimping on care and so forth. So I think quality has become sort of a central part of and integral to value-based payment models. Next slide. So what are the goals of VBP? What is VBP really trying to accomplish? And I think I wanted to spend just a couple of minutes talking about the aims of VBP, which are really at this point fourfold. They start off as being the triple aim, as many of you might have heard or read about, which is better care, you know, better health or healthier people and lower costs. More recently, the quadruple, the fourth aim was added, which is improving the work life of healthcare providers. So there's been a lot of talk recently, both from Medicare as well as from others in the field, about burden reduction, and I think that's really where it's coming from, is making sure that you know, the physicians or clinicians are not feeling you know, a lot of burden as they're you know, going on about their day-to-day work of providing care to patients. So this is essentially this four-part aim, if you want to call it, has you know, sort of become the goals of all value-based payment models. Next slide. So before we talk specifically about the kinds of measures and how quality is measured in the context of value-based payment models, I just wanted to take a couple of minutes and talk about the quality measurement enterprise and some basics around quality measurement. So quality measurement is not new. I think today we're focused primarily on talking about measurement in the context of value-based payment. But for the past, you know, several years, I think, you know, long after the Institute of Medicine report, or Human, was published, as well as, you know, seminal work by Beth McGlynn that actually looked at, you know, rates of adherence to guidelines and the fact that there were huge quality gaps in this country. Since then, there's been tremendous focus on measurement in this country, and a whole sort of enterprise exists to promote, you know, quality and advanced quality measurement. And typically, that starts with the whole measure development. And here, there are a number of organizations that I'm sure many of you are familiar with, such as NCQA. You know, CMS obviously funds a lot of measure development, as well as the specialty societies that are actually involved in developing measures, and there's a sort of a structured and rigorous measure development process that these measure developers adhere to. And typically, this process involves identifying topics or clinical areas that are of high priority. Either there's high prevalence of a particular condition, or you know, we're spending a lot of money, so these conditions are high cost areas. And so, wanting to assess the quality of care received by patients in those, for example, high prevalence, high cost areas, is sort of the first step in the measure development process. And then once, you know, the area has been identified, as well as the measurement concept has been identified, then the actual process of specifying the numerator and the denominator of the measure begins, in addition to testing of the measure itself. So then once measures get developed, typically they go through the National Quality Forum for measure endorsement. The National Quality Forum actually uses a consensus-based process and technical expert panels to review the measures that get submitted to them for endorsement. The measures are then evaluated against a set of criteria that are available publicly on the NQF website for those who are interested. And typically they're looking at things like, you know, is there an evidence base for the measure? You know, is the measure valid and reliable? Is it feasible to collect? You know, is it usable? So they have a set of criteria that they use to assess measures, and measures that pass those criteria get endorsed by NQF and then become available for use and can be are implemented or adopted in the field. That's not to say that every quality measure that gets developed and is implemented goes through endorsement. Most measures do, but there are also measures that get developed that don't necessarily go through endorsement but are implemented and taken up in the field. The last I checked, there were about 547 endorsed measures listed on the NQF website. So as you can see, there are a lot of measures that go through the process that get developed. And typically, who are the implementers? There's NCQA. Obviously, they adopt measures to assess health plans, but today we're talking about value-based payment models. So we're talking about measures as they're adopted by payers, you know, CMS, states, health plans, and maybe, you know, purchasers, but also specialty societies use a lot of measures for quality improvement purposes. Right. So in addition to, talking about the measure development enterprise, I just wanted to talk a little bit about, the different types of measures that, quality measures that get developed, because the type of measure and how, and the purpose of a measure actually are important to consider when thinking about measures for value-based payment. So many of you might be familiar with the Donna-Bedian framework that essentially classifies measures into structure, process, and outcome. A structural measure essentially assesses, the features of an organization. So, for example, what's the nurse staffing ratio, or, how much EHR adoption is there within an organization. Process measures, I think Lena sort of alluded to them at the beginning of the talk. Those are typically assessing clinical process of care. So examples would include things like, did a diabetic get a hemoglobin A1C test performed, or did a diabetic receive an eye exam or a foot exam? So those are examples of clinical process of care measures, and typically those measures are based on evidence-based standards. And then there are measures of outcomes that essentially assess the health status of a patient, and they're typically the result of a one or more healthcare interventions. So examples of outcomes measures are, was the blood pressure for a diabetic patient controlled, or was the cholesterol for a diabetic patient controlled. So those are all, examples of outcomes measures. And it's kind of, this framework is useful because, again, there are, you always want to think about measures as those that are fit for purpose. And in VBP, we're talking about paying for value. And so thinking about the types of measures that are fit for that purpose, I think, is important in the context of VBP. Just also wanted to touch upon the different data sources that are used to calculate quality measures. I'm sure all of you are familiar with claims-based measures. So these rely on administrative claims data, which could include both laboratory claims as well as pharmacy claims. Then there are measures that rely on clinical data that typically come from the medical record. In the old days, it used to be a lot of chart abstraction from paper charts. With increased EHR adoption, I think there's still extraction that occurs, but now it's being extracted out of an electronic record. Another source of data for quality measures are clinical registries. These are typically established and led by, specialty societies. Examples include the National Cardiovascular Disease Registry that's run by the American College of Cardiology, or the Surgical Quality Improvement Registry that's run by the American College of Surgeons. So those are all examples of, registries. And then there are patient-reported measures that, again, I think Lena spoke to this earlier, that rely on data that's collected directly from the patient. So typically standardized instruments are used to collect the data from patients, and then those data that are collected then help feed, the calculation of measures. Examples of these kinds of measures include things like patient functional status, what level of pain are they experiencing, what level of mobility do they have. So those are all examples of patient-reported data that are used to calculate measures. So that was just to kind of level set and talk about a little bit about, how measures get developed, what types of measures are available, and then also what data sources are used to calculate quality measures. I wanted to, again, this is again part of the level setting a little bit, to say that there are different kinds of value-based payment models, and I talked about that a little bit earlier when we showed the framework, the APM framework. And I think broadly you could categorize them into population-based models. Typically, they tend to be primary care focused. And they're, as you all know, either patient-centered medical homes or ACOs, or they could be specialty focused. They're typically bundles or episode-based value payment models. And the more common areas where these kinds of specialty models are implemented are in oncology, orthopedic surgery, as well as maternity care. As I explained before, there are, over 500 measures that have been endorsed by NQF, and of course, not all of these measures are necessarily in use or have been adopted in the field today. And not all of these measures that have been developed and endorsed, may be suitable for value-based payment. So in selecting measures for VBP, it's important to recognize that one of the main purposes of measurement in VBP is for selection and accountability. And so what do I mean by that? Measures that are appropriate for selection are essentially to help patients or consumers, and to some extent in these value-based payment models, providers to choose high-quality, physicians or physician groups or hospitals and health systems. Essentially, you're helping patients select high-quality providers, or you're helping providers themselves refer their patients to other high-quality providers. And then the other part to this is accountability. So these are really measures that hold providers responsible for a patient's health or health status. So again, in thinking about measures for VBP, you want to sort of be thinking about, in selecting measures, are these measures going to be appropriate for selection? Are these measures going to be appropriate for accountability? Again, it's back to that fit for purpose idea. And then finally, again, like I said, that the types of measures that you select will also depend on the kind of model that you're implementing. Whether you're implementing a PCMH or an ACO-based payment model, or you're focused more on a specialty model. Next slide. In addition to the kind of model that you're implementing, as well as in terms of, thinking about our measures fit for selection and accountability, there are a variety of other criteria that are used in selecting quality measures in value-based payments. And what you see listed on this slide are examples of some of the criteria that are currently used. So as I mentioned before, in picking measures, you want to make sure that the measures are scientifically valid, that they have an evidence base to them, and that they are reliable. And for the most part, if a measure is NQF endorsed, they're going to naturally meet those set of criteria. You also want to be thinking about, is it possible for me to collect the data on these measures? Typically, if it's a payer and if you have administrative claims and it's a claims-based measure, then you have access to the data source. But if it's a patient-reported outcome measure, you may not have the infrastructure to collect the measure, and therefore you need to be thinking about that. You also want to think a little bit about the burden versus the benefit. In some cases, yeah, it might be costly or it might be burdensome to collect a measure, but you also want to be thinking about, what benefit would I derive if I were to collect and implement this measure in my practice, or as a payer if I want to include this in a contract. And then lastly, I think the other area that typically payers tend to look at is, especially if you're not Medicare, is how do the measures that I'm picking, how do they align with what Medicare is choosing? Organizations may also be looking to pick measures where they see opportunities for improvement. So in thinking about which measures you want to implement, you also want to see that there's actually significant gaps in performance, and therefore you want to focus in areas where there are gaps in performance. If measures are topped out, essentially everybody's performing at the highest decile or 98% or whatever, then that may not be an area where you want to be picking a quality measure. Slide. So I'm going to talk a little bit about the measurement in the context of population-based payment models. So I want to first, describe some of what I call the domains of measurement. So here again, these are models where providers are taking on responsibility for managing a whole population. And so typically measurement in these models, especially as it relates to what the kinds of areas the plans are focused on, fall into these categories or measurement domains. So there's, focusing on prevention, and I'm going to talk about each of these in just a little bit in terms of the kinds of measures that lie in each of these domains. And then secondly, there's, treatment and management of, chronic conditions. Plans tend to also look at measures of utilization, which in some cases could actually be measures of quality, and I'll talk about that in a second. Patient safety, patient experience, and then also focused on overuse or inappropriate use. So typically when you look at programs, whether it's ACO programs or PCMH programs being implemented by payers, these are, most commonly measured domains or included domains in VBP models that are population-based focused. Next slide. So what are the kinds of measures that are used in each of these domains? So I want to just touch upon that a little bit. Obviously, this is not an exhaustive list. So this is just to give you a flavor of the kinds of measures, or quality measures that are included in population-based payment models, namely ACOs and patient-centered medical homes. So on the prevention side, measures are typically around, getting appropriate cancer screenings, breast cancer, colon cancer, cervical cancer, childhood immunizations, well visits for children, and also, ensuring that adults are maintaining a healthy body mass index. In terms of the treatment and management of chronic disease, again, the focus is on common chronic conditions, high prevalence conditions like diabetes and cardiovascular disease. In the case of pediatric populations, the focus would be on asthma. And then we're also seeing focus on depression and hypertension. Examples of the kinds of measures, for example, with diabetes, it's essentially making sure that the diabetics are getting all the recommended services. So, is their A1C, hemoglobin A1C tested, and is it under control? Is their blood pressure under control? Are they being screened for, diabetic nephropathy, for example? So again, some of them are purely clinical process of care measures like the A1C testing, and then others like A1C control or blood pressure control are what we would call intermediate outcome measures. With cardiovascular disease, same kind of thing. It's both ensuring blood pressure control, but also looking at things like, persistence of beta blocker after a heart attack. So there are similarly for asthma and depression and hypertension, either measures that look at adherence to medications, or in the case of depression, it's actually assessing, remission at 6 or 12 months after diagnosis. What? Some of the utilization measures, again, looking at things like readmissions, preventable ED visits. Again, they're classified as, measures of readmissions or measures of utilization, but they're really actually measures of quality because, if you ask the patient, they wouldn't really want to be, saying, yeah, I want to show up at the ED or I want to be admitted in the hospital. So keeping them out of the hospital is actually good for the patient. And so, I think, they're characterized as utilization, but they're more than that. And you see some examples of the patient safety measures. Patient experience, typically these are calculated and reported out using the CAP surveys. And then finally, overuse or inappropriate use measures, looking at things like appropriate imaging for low back pain or appropriate treatment for adults with acute bronchitis. Next slide. So those are the kinds of measures that are typically used in VBP models that are focused on population, managing populations, so ACOs and patient-centered medical homes. I want to talk a little bit about the kinds of measures plans are using in specialty payment models. And again, I think most of the models that we're seeing in this area, which are either episode or based or bundled payments, are in the areas of oncology, joint replacement, and maternity care. And as you can see from the slide, the focus or quality measurement for these specialty models is much narrower, because you have a much better defined population here. So in the case of, joint replacement, it would be somebody who's going in for a knee surgery or a hip surgery, for example. So you want to be measuring quality of care for those individuals. Many of these measures, as you can see from the slide, assess outcomes for patients. And for some of the areas, such as the measures in oncology, I think having access to clinical data is going to be really important. So, one key data element that will be important for oncology would be, cancer staging. And that will actually play into the kind of treatment that a patient might receive, but would also be important in the context of quality measurement. But, such information, such as staging data, for example, right now is not as widely available. And I'll talk a little bit later about some of the challenges that continue to exist in the space of quality measurement. But again, this slide gives you a flavor for the kinds of measures that are being used in specialty models. Again, not an exhaustive list, but these are the more commonly used measures. And again, these are measures that, several of them have gone through a more rigorous measure development process and, and might also have received endorsement by the National Quality Forum. So far I have focused on talking about measures that are in use by health plans. So I wanted to switch gears a little bit and talk, give you a flavor of the kinds of measures that are used in the programs in Medicare. But before I talk about the measures themselves, I just wanted to set the stage and do an overview on MACRA, which I'm sure all of you are familiar with, but this is just a level set. So MACRA, as you all know, was signed into law in April 2015 and created sort of two pathways for physician payment. One is what is commonly known as MIPS, which is the Merit-Based Incentive Payment System. And this path offers potential bonuses or penalties depending on how eligible professionals perform in 4 categories, quality being one of those 4 categories that clinicians are assessed on. The other track is the alternative payment model path, and here clinicians who participate get a 5% bonus. And again, their participation is and their ability to earn a bonus is based on a set of conditions that you see on the right-hand side that displayed on the slide. And so in each of these pathways, CMS actually, goes through an annual rulemaking process where they put out the list of measures that they're considering for the programs. And both of these pathways involve assessment of, quality of care that's provided by these clinicians who are participating in Medicare. Next slide. So this slide shows you a little bit about the summary slide, and it just counts up the number of measures that are used by CMS in a variety of its alternative payment models that they've implemented through the Center for Medicare and Medicaid Innovation. So the CMMI models fall into both categories. So they have models that are population-based. Those include like the Medicare Shared Savings Program, the Next Gen Accountable Care Organization, or Next Gen ACO program. So, and then as well as the Comprehensive Primary Care Plus. So those are population-based models. And then they also have specialty models such as the CJR, the oncology model, as well as the Bundled Payment for Care Improvement Initiative, which is now the Advanced VBP program. And each of these measures, as you can see, the number of measures in these programs vary. Some are very few, like 7 in the VBP program compared to 24 that's currently proposed for the Medicare Shared Savings Program. And then, and as few as 2 for the CJR, program. Next slide. So what is Medicare measuring relative to its population-based models? I think with the shared savings program, typically the domains are similar to what the health plans are measuring. So they're looking at patient caregiver experience, which I've characterized before as patient experience. They're looking at care coordination, patient safety, preventive health, and then clinical care for at-risk populations, which is really measurement of quality of care for people with chronic conditions. Examples of measures in each of these programs, they include things like, for example, with preventive care, again, it's looking at things like tobacco cessation, cancer screenings, whether there was statin therapy for prevention of cardiovascular disease. In the case of care coordination, patient safety, they're looking at things like, readmissions, ambulatory care, sensitive admissions. And then with the patient experience, again, it's measured through the use of the CAP survey. So those are all, that's not an exhaustive list again. I think the CMS measures are publicly available for people interested and want to take a look at it after the webinar. But again, this gives you a flavor for the kinds of measures that are incorporated in sort of Medicare programs. Next slide. And then this slide kind of gives you a flavor of the kinds of things that are being measured in the specialty models being implemented by CMMI. Again, for the comprehensive care for joint replacement, they're really looking at complications measures as well as assessing patient experience through the use of HCAHPS, which is already being collected by the hospitals. And then for the VBP, again, this, the kinds of measures that they're looking at, or some of them are utilization measures like readmissions. They're looking at complications, mortality, length of stay, but also focus on things like patient safety. Next slide. Oncology care model, I think, again, it's a mix of utilization measures and other areas that are obviously very specific and important for oncology, like pain assessment and management and depression screening, timeliness of chemotherapy, and things of that nature. So, I think what the goal here is to really be able to get the right kind of measures that will give, a more comprehensive picture of the quality of care that's being delivered to the patient. Right? I also wanted to just give you a little bit of an understanding of the kinds of measurement that's being used in Medicaid. Again, I won't be going into too much detail over the specific measures that are each of these domains, except to say that these domains are very similar to what we've seen before in terms of what Medicare uses as well as in terms of what the plans are using. So there's always a focus on prevention, chronic care management, utilization, and patient experience. But the one thing that is, certainly true is that given that there are 50 states, there tends to be quite a bit of variability in the measures that are chosen in each of these domains. Although I think the states are making a concerted effort both to align their requirements with what CMS is doing relative to their adults and CHIP core set, but they're also looking to organizations like NCQA and NQF and the Agency for Healthcare Research and Quality and selecting measures that have been developed and endorsed by these national organizations. So even though there's variability, I think states are trying to align with national programs and also choose measures that are being developed and being made available by well-recognized measure development organizations like NCQA. Next slide. So we've talked a lot about measurement and the fact that measures are integral to VBP because you really want to assess performance and make sure that we as a country are making progress towards the goals that the VBP is seeking to achieve. But then, are we really deserving value? And are we delivering value? And has there been any progress in terms of improvements in quality? So this slide just shows you some sampling of the kinds of results that are being reported by health plans. Again, it's not an exhaustive list of all the results that are out there, but as you can see, in terms of the kinds of things that the health plans track, you can see improvements in ED visits, inpatient admits, also improvements in clinical quality in terms of better management of common chronic conditions such as diabetes and cardiovascular disease, but also increasing the uptake of things like preventive screening. At the same time, plans are also reporting cost savings. Even though I talked a lot about quality measures, I think a lot of people are paying attention to cost measures as well because affordability is obviously a major goal of value-based payments. Next slide. And then similarly for Medicare program, CMS publishes results of their various programs, and then you can see some of the outcomes from these programs summarized on the slide. So again, some improvements in quality. In some cases, the programs have had some mixed results, as you can see. But overall, I think there's been improvements in quality as well as some cost savings that have been generated through the implementation of these value-based programs. So if we weren't measuring, we wouldn't know what kind of progress we're making. And so from that standpoint, these kinds of measures actually serve as a yardstick for, how well we're doing at various levels of the health system. So we have a lot of, measures that are being developed. We have a lot, number of measures that pertain to important areas that are being adopted in value-based payment programs. But that doesn't mean that challenges don't exist. So what this slide captures is sort of 4 challenges that I wanted to talk about today as it relates to quality measurement, and specifically in the context of quality measurement for value-based payments. The first is a lack of alignment, and I'll go into a little bit more detail on each of these. Then there's, lack of an appropriate data infrastructure, which I'm sure many of you on the phone are familiar with. Lack of, quote-unquote, meaningful measures, as well as sort of a costly, time-consuming process, both in terms of the measure development, but also the measure implementation and the data collection piece. Next slide. So the first challenge I want to spend a little bit of time on is the lack of alignment. And so what you see on the slide are a few data points. So in my in my previous life, I actually sort of led a study where we surveyed plans and we wanted to understand, what kinds of measures that we're using in their contracts with payers. And, I have to realize that this study was done a few years ago, almost 4 or 5 years ago. And so what our study found was that, there were about 546 measures that were being used by private payers in their contracts, but only about 26 of them that were HEDIS measures were used by half of the plans. So, and in addition, we also found lack of congruence or alignment between measures that were used by the plans and measures that were used in Medicare programs. Other analyses have shown sort of similar variability when they looked at use of measures by state. So sort of the general conclusion is that there's a lot of, what's called as measure cacophony. And the measure cacophony is arising from sort of for two reasons. One, even though the domains of measurement, as you saw earlier, were the same, the specific measures that were being chosen, for example, with diabetes, there are 3 or 4 different measures of A1C control. So each payer could pick a slightly different measure of A1C control if you're trying to measure diabetes. So that's where kind of the variability comes in. And then there are whole areas where, sort of standardized measures don't exist. And again, that's another area where there's variability in measurement. So this was sort of a problem that was identified several years ago. And in addition to the actual measures varying, there's also variations in the measure specifications. So even though I might pick A1C control, greater than 9, the way I define the numerator and the denominator for that particular measure might vary because I may not have the same data available to me as somebody else in terms of calculating the measure. So that's another sort of source of variability that occurs in quality measurement. And so one of the things that the field has been working on is, next slide, is to actually get to better alignment across public and private payers. So I want to spend a little bit of time talking to you about the Core Quality Measures Collaborative. So this was work, again, that I was involved with a few years ago, but it's ongoing work. And this was really an effort, a multi-stakeholder effort, to align measures across commercial plans as well as Medicare. And what's displayed on the slide is actually the 3 aims that the Core Quality Measures Collaborative, or CQMC, was trying to achieve. So first, wanting to make sure that we're picking high-value, high-impact measures. 2, that we wanted to reduce the burden of measurement and balance the burden versus the benefit. And then 3, sort of refine, align, and harmonize measures across payers to really achieve congruence in terms of the measures that we use for payment as well as for other accountability programs. Next slide. So what did the Core Quality Measures, or CQMC, work on? So the CQMC decided that it couldn't tackle all of this problem of lack of alignment across multiple areas. So wanted to focus on areas that were high prevalence, high cost, or areas where there was great variability in practice patterns. And so the CQMC identified these areas as initial areas of focus for achieving measure alignment. And so the work itself was conducted through multi-stakeholder work groups, and there was a steering group that helped guide the overall effort. And so it was very much sort of a consensus-based process where for each of these areas, the work groups met multiple times over 2 to 3 years, considered exhaustive measure sets and lists of measures that were currently in use, and then based on review and discussion of those lists, selected a core set for each of these 8 areas that you see listed on the screen. And these measure sets are publicly available. They're posted on the CMS website. They're also posted on the AHIP website in case, after this webinar, people are interested in knowing what these actual measure sets are for each of these clinical areas. Next slide. So who was involved? So as I mentioned earlier, it was a multi-stakeholder effort. Involved the payers, CMS, and the plans, but also involved all the relevant specialty societies, states, the National Quality Forum, as well as consumers and employers. So again, it was a multi-stakeholder process, and it was also a consensus process. And then out of this process, a list of core measure sets for each of the 8 areas that were on the previous slide were made public. So it's been a couple of years, I think, since the measure sets were announced. So, what kind of progress have we made towards alignment? So this slide shows the progress that's been made towards alignment. So AHIP Foundation conducted a study of health plans in 2016-2017 to assess adoption of core sets. And as you can see, there has been quite a bit of progress that has been made towards adoption. And then, it also turns out that the ACO PCMH/primary care core set had the highest adoption rate. And so I think that's also a reflection of the fact that a number of the plans are implementing population-based payment models and therefore more likely to adopt those measures. But it's also true that the specialty measures that were part of the CQMC required use of clinical data. And so it's currently an infrastructure doesn't exist for plans to access clinical data easily, and therefore adoption is also a reflection of the fact that the data for some of these measures are not readily available. And that's something that also came out of the
Hi. We may be experiencing some technical difficulties. Could the audience share in the comments whether they can hear me or not? Okay, we are good to go.
Okay. All right, good. Thank you. So anyway, so as I was saying, I think the part of the reason why adoption of some of the specialty measure sets has been slower is because of this issue of data infrastructure. Next slide. So that leads us to talking about the other challenges associated with quality measurement. And one of the main challenges, as you all are probably aware, is lack of an adequate data infrastructure. So this problem can be sort of thought of as this lack of interoperability, and I'm sure all of you are familiar with that, although there are provisions in the 21st Century Cures Act that seek to address it, and CMS has also placed an increasing emphasis on ensuring interoperability, as is reflected in their proposed rules that have been issued. And also, as we heard from an earlier webinar hosted by CAQH, where we had someone from ONC speak about interoperability. So there's several efforts afoot to help address this issue of interoperability. Then this issue of lack of data liquidity, which is essentially your ability to port data from one place to another. And then ongoing challenges with use of EHRs for quality measurement. And that's driven by a variety of factors. So, for example, there's wide variety or variation in EHR implementation. So implementation of the same EHR can vary from one practice to the next. Data for quality measurement are not always captured in a structured format, so sometimes it might be in the notes section, and so extracting that data might be difficult. Efforts that are aimed at comparing quality performance data found differences in electronic quality measure rates generated across EHRs. So there's a lot of issues to be addressed in terms of using EHR data for quality measurement. So but there are, again, efforts underway to help address those challenges. Secondly, there's this issue of lack of meaningful measurement. And what do I mean by that? So first is this issue around relevancy. How relevant are the quality measures that are being used today for specialists? And I talk to specialists and I hear from them. They say that a lot of the measures that are currently being used are more primary care focused, and so there aren't enough measures for specialty care, especially ones that are standardized and perhaps even NQF endorsed. You also hear a lot about the existing quality measures not being useful to patients, and I think the reason for that is you have to think about quality measurement and how the current measures got developed. They got developed within the context of a fee-for-service system, and so as we're moving from a fee-for-service into a value-based system, the measures that were useful and maybe fit for purpose in a fee-for-service system may not necessarily be good and fit for purpose in a value-based payment system. And typically when patients are looking for, quality measures and performance data, they're more interested in, in learning about the outcomes of care. And there's research that kind of looked at what patients are, what kind of measures and performance data patients are interested in. And they are interested in things like complications, for example. They're not necessarily wanting to know if the A1C test is performed. And for most patients, they don't really understand sort of the clinical process of care measures. And then lastly, I think, again, current quality measures are very siloed in the way they assess care. And that really means that they're focused on much more on a setting. So we have measures for hospitals, we have measures for clinicians. What we really need is a measurement system that sort of looks across, sites of care, longitudinally, both in terms of care settings, but also in terms of, time. Because as we think about, measurement for diabetes, for example, we not only want to know if somebody received their A1 test, but we also want to know if we prevented, for example, short-term as well as long-term complications from diabetes. So having that longitudinal view is going to be, really important. And then, so again, more work needs to be done in that area. And then I also say that both the measure development process, but also, the measurement collection or the data collection for measurement is very costly and time-consuming. I think Lena talked about the hours physicians spend in collecting data for quality reporting. That number translates into annually $15 billion to report quality measures. Again, and it's a costly process, so we have to, figure out ways to collect data more efficiently and in a much more reliable way as well, because we do want to maintain the integrity of data collection and ensure that the performance data coming out of it are valid and reliable. There's a lot of work happening to address these challenges, both from the private sector perspective, but also from the CMS perspective. And I want to spend a couple of minutes sort of talking about that. So how should we be thinking about quality measurement going forward? So I think it will be important first, in keeping with the quadruple aim, that we should be thinking of measures that focus not just on healthcare quality, but also focus on measures of health. So that would include things like health-related quality of life or general well-being measures that might focus on health versus measures that focus on outcomes from care delivery. Secondly, as I've already stated, it would be important to have a longitudinal assessment of patient care, or as I like to call it, across the space-time continuum. So, across care settings, but also over time. We also need measures that better integrate primary care and specialty measurement. So as we're moving more into team-based care, so it's not just the individual physician delivering care, but what we're seeing in these new models is that it takes a care team to deliver the optimal care to the patient, and therefore we need better ways of measuring the integration of primary and specialty care. And then all of this leads us to sort of the conclusion, at least leads me to the conclusion, I should say, that the primary focus of measures in value-based payments should be measures of outcomes. And I think there's a growing realization of that. For example, I talked about the Healthcare Payment Learning and Action Network previously. They put out a framework paper on measurement for population-based payment models where they emphasize the need and the importance of using primarily outcomes measures in the context of population-based models. Those measures of outcomes could be clinical, they could be patient-reported, they would also need to assess, patient experience, and you also want to think about cross-cutting measures that are not necessarily condition-focused like diabetes or cardiovascular disease, but looks at things like ambulatory care sensitive conditions, for example. And then also it's important to get all that measurement done, you need a better data infrastructure through data liquidity. And there are several efforts underway to help make that happen. And, one of the main ones in this area is, CMS recently announced the Blue Button 2.0 initiative as part of its broader My Health eData initiative. Essentially, Blue Button 2.0 is an application programming interface. It's an API that enables Medicare beneficiaries to share their claims data with third-party apps, for example. And so they recently announced the launch of this API. As I mentioned previously, there's increased focus on interoperability under MACRA. And then CMS is also encouraging health plans, just like they are, to share claims data with their members. So CMS is sharing claims data with its beneficiaries so they can port that data wherever they go. So there's a lot of work underway, but a lot more work needs to happen. But I think it's important as we think about measurement, and since measurement is so central to VBP, that we pick the right kind of measures and measures that are fit for this purpose, which is primarily for selection and accountability. So Jessica, and with that, I'll turn it back to you.
Thank you, Aparna. I know I learned a lot listening to your presentation. I'm sure our audience did as well. So I think we have time to take 2 questions. So the first question is, are providers interested in value-based payment, and how engaged are they in these efforts?
Okay. So providers, what I hear is that they are interested in moving to value-based payment, but not all providers are actually ready to move into some of the more advanced models. And I showed that graphic with, moving from category 1 to category 4. So you might have providers who are at sort of different points on the spectrum relative to value-based payments, depending on the readiness. So there might be some that are in models where it's still fee-for-service, but there might be a care management fee along with a pay-for-performance incentive, all the way to providers who might be in global budget models or global payment models. They're taking on full risk. So I think it really varies on how ready they are, and it's a journey, and I think people are realizing that.
Okay.
Yeah.
So people are going on this journey.
Yes, and I think if people are interested in sort of hard facts, the LAN actually measures adoption of value-based payments, and in terms of dollar numbers, and calculates that and makes that information public. And maybe after this webinar, you might want to share the link with your listeners.
That's a great idea. And then the last question is, how can integrating pharmacists in outpatient settings assist providers with the challenges in VBP?
Okay. So what I have seen in my experience, the way pharmacists are used is really in the area of medication reconciliation. And I think that's where making sure that, everybody knows what meds the patients are on, and that could include prescription drugs, but also, over-the-counter drugs. So really having a complete medication list and having it reconciled. Pharmacists are also used in terms of interacting directly with the patient to talk to them about how they should take their medications and educate them better. So that's a huge source of readmissions, actually, and it's tied to readmissions. So those are ways in which pharmacists are being integrated into these value-based models.
That makes sense. And thank you very much. We are out of time. If we could go on to the next slide. We've listed our next webinar in September, as well as a presentation in October on VBP that our director, Erin Weber, will be giving at the Value-Based Care Summit. And if you will be attending that summit, we hope you'll attend her session. And then on the next slide is some information on ways to engage with us and contact us if you want to hear more about what we're up to on VBP and other lines of work. Thank you for joining us, and have a great afternoon.